I'd like to invite Dr. Sandeep Mitra to speak to us about know your options before you start your surgery. Dr. Sandeep Mitra is a senior consultant in the United Arab Emirates, and he worked in Australia, UK, and so Dr. Sandeep Mitra, please go ahead.
Thank you. Actually, the presentation I'm going to give today is more of a questions asked by patients. And in fact, I'm going to be in the side of the patient, and I will give these questions to my next presenters and try to understand what you should do when you have a refractive lens exchange. So the headache is that it's an expensive procedure, number one. Number two, the patient has a lot of expectations from you when you go for a multifocal implant in these patients, because not only they are paying premium, they're expecting premium results from you. So that's it. So the first thing is when to stop, not to proceed. You should not be, so very high expectation patients, send it to your immediate colleague who you love. Untreated dry eyes, don't do them. Irregular corneas, again, if you can correct these irregularities with laser, yes, you can approach, but it's a challenge. Previous refractive surgery, again, it becomes plus minus. You can proceed, but it requires an extra effort. Retinal issues, these are absolute no. Retinitis pigmentosa and Stargardt's disease, you should not do a multifocal lens. Optic nerve issues, again, a negative. Dementia is basically a consenting issue for the patient. So a dementic patient, you have to be very careful when you put a multifocal lens. And intraoperative issues, if you have challenges like zonular loss or a posterior capsular loss, you have to be careful. If you can center the lens properly on the visual axis, yes, otherwise don't proceed, because they can get decentered post-op if you leave behind vitreous. What are your choices? Basically, you are trying to correct a good distant vision, go for monofocal. A distant vision correction is better corrected with monofocal or monofocal toric, and give them presbyopic glasses. They will be the most satisfied patients. Astigmatism more than 0.75 is preferably corrected with toric lens, or you can use steeper axis incision or laser cuts. This is an article which was presented in 2019, which actually reviewed various types of trifocal, bifocal, EDOF lenses, and the surgeons came up with their plus and minus. Some of this I'm going to talk to you now. So what is this trifocal lens? Trifocal lens basically splits the light into different focus, usually between 60 to 80 centimeters. That's where you get an intermediate vision. So you get a good near vision, you get a good intermediate vision, and you get a good distant vision. That's what a trifocal lens should be. Whereas an EDOF lens, or extended depth of focus lens, is basically a continuous range of vision without dropping out in between specific points. So that's what the EDOF lens is all about. So it doesn't give you a very good near vision, it gives you a good intermediate and distant vision. So trifocal lens gives a better near vision compared to EDOF lens, whereas EDOF lens gives you a better intermediate and distant vision. So, and the other question is when to go for toric lens. So you can have now toric trifocal, you can have a toric EDOF, and these are important when you are correcting astigmatism, which is more than 0.75. EDOF lens will tolerate higher degrees of astigmatism compared to trifocals. The other problem with any multifocal lens is chromatic aberrations, and this is because of the higher refractive index. Now, the higher power of lens you use, the refractive index has to be higher to make the lens thinner so that it becomes foldable. And these lenses, so when you use a higher power lenses, your chances of dysphotopsia is more. So that's another problem with, especially with hydrophobic IOLs which you use these days. So what is dysphotopsia? This is what you can show to your patient, that this is what you can expect in most of the trifocal lens, whether it is a refractive trifocal or is a diffractive trifocals. Whereas the EDOF lenses have got less dysphotopsia compared to a trifocal lens. Whereas in the 2019 Heidelberg in Germany, they came up with an idea wherein they actually coated these trifocal lens with an EDOF lens, and they produced something which probably will have the benefit of a trifocal and EDOF together, but it probably still not in the market. The most important point is patient counseling. If you fail this, I think that fails your surgery. So any premium IOL, you need to take time off and sit with the patient, explain to them properly the problems they will face post-op. Whether it question of getting rid of 100% of glasses or some glasses post-op or some treatment with laser post-op or exchange of IOL post-op, this you should mention it, otherwise you may face medical legal problem. And the other issue is posterior capsule opacification after trifocal lens or EDOF lens, because if you crack these capsules post-op, sometimes the patient who don't have dysphotopsia initially after the surgery actually start having dysphotopsia after you crack the capsule. So this is something which you need to see. You can personalize each and every patient depending upon the amount of requirement they have. So somebody might have more of intermediate vision and doesn't want a dysphotopsia, and somebody who wants more of near vision, you can mix and match. So you can put trifocal in one eye and EDOF in the other eye. So this is just a nice way to explain if in case you have problem after multifocal lens. So if you have a patient who is not satisfied, then immediately don't jump and try and explant these lenses. There could be multiple reasons. Starting from the ocular surface, it could be just simple dry eyes, which you can treat them, or it could be a corneal problem, which can be treated with laser, or it could be a retinal problem, which a retinal colleague can help you, or it's a capsular problem. So don't try and crack the capsule in all patients. So be careful what you do. Most of the cases you can circumvent without removing the lens. However, if you are planning to do a case which is challenging, it is better to put CTR, which is available these days, when you implant the IOL or trifocal lens, so that in case you need to remove this IOL or exchange the IOL post-operatively, it's better to go ahead and have a CTR there, and it's easy for you to remove these IOLs. So in summary, we are still waiting to get a perfect premium IOL. Probably the best one will be a combination of a trifocal and extended depth of focus lens. And we hope to see this IOLs in near future. Thank you very much.
So I would like to thank you very much, Dr. Sandeep, for this lecture. I would like